Hello, my name is Adam Singer, and I'm a diagnostic radiologist from Atlanta, Georgia. And today I'm going to be discussing Diagnostic and Interventional MSK Ultrasound. This topic is a topic that's being discussed in general, but also can be used for board review for the radiology core exam and certifying exam, touching on basic topics that you may encounter on such examinations. A reminder, this video and all the videos contained in my channel are for educational purposes only and should not be used to guide medical decision making. If you have a medical condition or issue, please consult with your doctor before undertaking any sort of medical intervention. With that said, I'll begin. So there'll be 5 learning objectives, the 5th really not being an objective, but just an example of some cases that you may encounter, both in real life and on examinations. But I'll begin by reviewing the basic sonographic terminology. Then I'll describe the typical devices used in Injectate materials for musculoskeletal ultrasound-guided procedures. We'll review the basic sonographic anatomy of the shoulder and the knee, and there will be an MRI correlation. And finally, we'll become familiar with some of the common and selected, in this case, MSK ultrasound-guided procedures. I am going to have a link at the end, or not a link, but at least a citation list to see some of the places where the evidence comes from. This is a brief overview, so I can't really delve too deeply into the evidence behind all of these procedures, but there will be a couple of quick summary bullet points on the bottom of each slide section, and then the references at the end. I would encourage anyone who's interested to take a look at some of these sources and even further peruse the literature just to get an idea of how effective some of these interventions are and what the evidence is behind them. So we'll start with the terminology. When we talk about ultrasound imaging, at least for musculoskeletal ultrasound, we talk about the long and the short axis. And so this is just an example. This is my crude drawing of an ultrasound probe, and this would be long or short axis with respect to the object that you're imaging. So in this case, this is the Achilles tendon here. Here's an MRI showing the same area. I just blew it up over here. And if you look, we see Kager's fat pad back here, the calcaneus this way, the underlying soleus over here. And on the proton density image that we have here, you can see the dark signal of the tendon. You almost can see there's sort of a linear fibrillar pattern of the tendon as you're going through it, but it's really not as apparent until you go to the ultrasound. You can see that pattern here, the microstructure of the tendon, to a much better advantage, in part due to the better spatial resolution. Notice the normal appearance of the tendon here, and then this mid-substance area of tendinosis, where the tendon, because of degeneration, has focally thickened, and that's this area right here. So you have a more normal, relatively more normal appearance over here, and then it focally thickens with this mid-substance tendinosis. In short axis, we again see the tendinotic area. There's an increased AP diameter here of the tendon. This is not the same area and the same tendon, but this is basically where you would put the probe to see something like this. So you're looking at the short axis, the cross-section of this Achilles tendon. One of the things that you'll encounter both on your core and certifying exams in radiology and in real life is the problem of anisotropy when we're talking about tendons and ligaments. And so in the case of tightly organized structures such as tendons and ligaments, where you have these collagen fibers that are arranged in parallel orientation, if the beam is not directed perpendicular to the structure, some of the sound beams may bounce away from the structure and not reach the transducer, and it may appear hypoechoic. And so this can be mistaken for pathology, potentially tendinosis or tears or things of that nature. So you really want to make sure that you're not being fooled by artifact. And so this can also be a benefit, because if you're not sure what you're scanning, you're not sure if you're seeing a tendon or a ligament, you can use this artifact to your advantage to say, yes, this is a tendon. And so how do you beat this? Well, you rock the transducer. And when you rock the transducer, the tendons, because of their microstructure, are going to go from hypoechoic to hyperechoic. And so when you're looking at it just correctly, it should look hyperechoic in a normal setting. So this is the long head of the biceps tendon within the bicipital groove here. And so this is an example of a more normal appearance, this hyperechoic rounded structure, and you can kind of see in cross-section these little fibrils running in and out of the plane. When you come over to this case, Again, you're in the bicipital groove, and there's this hypoechoic area here, and this is because of anisotropy. So you want to rock that transducer and make sure, especially with the biceps tendon, that it's in the groove and that it looks healthy, because if you don't see it there, it could mean it's torn, it could mean it's dislocated, and you just want to make sure you're not getting fooled by anisotropy. Alright, so moving on to the devices. We have an array of transducer probes that we use, and they all have different purposes, and they're constantly evolving. This is a little bit older now, but these are different types of probes you may encounter. The curve probes, these are often used for deep penetrations. These are low frequency, sometimes between 5 and 1 megahertz, and often we use these things for abdominal imaging, so you can see inside of the peritoneal cavity, look at the liver, look at the kidneys, etc., etc. So you don't get the great spatial resolution that you get with some of these probes, but you do penetrate further and you're able to see the structures that are deeper. As you move this way, we start moving toward the linear transducers. These are going to be higher frequency transducers, and so this means that the spatial resolution when objects are close up will be better than with the curved. However, we're not going to be able to penetrate as deeply, so we're not going to be able to see those structures as well, or even at all in some cases when there's a really high frequency. So we're talking about these high frequency probes, sometimes up to 15 megahertz and higher. And so in particular, this one right here has pretty high resolution. This is called a hockey stick. It sort of has a hockey stick shape, and we use this a lot in MSK, especially look at tendons and nerves and around structures that are curved like fingers and toes and things like that. It's very good for that, whereas the probe face is a little bit big here for these linear high resolution transducers to look at smaller structures that are curved like toes and fingers. So we often use this. If you look down at this table here, these are just an example of different types of injectates that you may encounter with some agents listed here. Local anesthetics, these are your canes. Lidocaine is a common one that we see used, but you can have others that act a little bit longer than lidocaine, which typically is a shorter acting duration. Ropivacaine, for example, being a little bit longer acting. And these will act to numb the patient. They block nerve action potentials, and there are potential side effects, especially depending on how much they're given. So these are local anesthetics. These are sometimes injected into joints and also for local anesthesia within the soft tissues around the target of whatever you're going after. Corticosteroids, there's a whole slew of the corticosteroids that may be used, particulate versus non-particulate. They generally cause an anti-inflammatory response and may be systemically absorbed and affect other areas outside where you injected. And there are potential side effects for these as well. As you start getting down to the middle and bottom here, you start looking into some of these, quote, biologics. And one of the hotter topics currently is this platelet-rich plasma, or PRP. You can get varying preparations of this, but essentially you take the patient's blood out, you centrifuge, and you isolate platelets, and in theory, the platelets and the factors they release will stimulate a response that will help heal structures. And so sometimes these are injected into muscle tears, into joints that are damaged, into ligaments that are damaged, tendons that are damaged. So this would be a biologic. There is an increased cost to this compared to some of these other agents, and the efficacy has been questioned. I think this is a topic that really warrants its own full discussion and a comprehensive review of the literature. But just keep in mind that there is this debate about the efficacy of PRP in many scenarios, similarly stem cells and things of that nature. Hyaluronic acid is another agent that sometimes is injected into joints and may act as a lubricant and provide analgesia. And then again, efficacy is questioned. There is some evidence to support the use of this, especially in joints. Again, beyond the scope of this discussion, autologous blood would be another potential injectate there. Alright, so moving forward, we'll review some of the basic anatomy. When you're doing a diagnostic ultrasound, a full exam, there are several structures that you want to have on your checklist that you examine. And so just a list of some of the key ones that I would probably make sure you include on all of your exams, and then there are some other ones as well that may or may not be included. Starting with the pec major tendon at the humeral attachment, the long head of the biceps tendon, subscapular tendon and muscle belly, supraspinatus, infraspinatus, teres minor probably, although usually this is normal, although the muscle belly may be atrophied, the AC joint and the subacromial / subdeltoid bursa. You may choose to go further. Look for the coracohumeral, coracoclavicular, and coracocromial ligaments. Check out the spinoglandin notch and suprascapular notch for nerve entrapment, the quadrilateral space for similar reasons. You can see part of the humeral head, and then ultrasound does afford you the ability to do dynamic maneuvers, looking for things like subcoracoid and subacromial impingement, and to dynamically assess the integrity of the rotator cuff. So as you have the patient internally or externally rotate their shoulder, the humerus that is, or you do it yourself, you can watch, and if the tendon has torn and retracted, you're going to see the stump sort of waving back and forth, but it won't be going all the way down to the footprint where it should be attaching. So starting with the pec major, this is short axis MRI. You can see the pec tendon coming towards the humerus, and here this hyperechoic pectoralis major tendon coming over and attaching to the humerus here, the ventral medial side. Moving then, as you move your transducer proximally, you're going to encounter in short axis the long head of the biceps tendon. So your probe is going to be sitting right here. You're going to be looking down. This is how you get the long axis here. But as you come proximally, the long head of the biceps tendon will come underneath where the pec was. And so here you see the bicipital groove, the lesser tuberosity here, the greater tuberosity here, overlying deltoid. And in the groove, this rounded hyperechoic structure, this is the long head of the biceps tendon. So you're seeing that right here. So your field of view is essentially this here. When you turn 90 degrees on it, you're going to see the long axis of the long head of the biceps tendon coming down, and here it is here. So that's the first part that you're going to do in the exam. Often with the patient sitting, their arm may be resting on their thigh with the palm up and in neutral position. The next thing you may want to examine in this position is going to be the subscapularis. So this is going to be the long axis. So again, sliding up and moving slightly medial, and you can see the tendon here. So this is the tendon coming over and attaching to the lesser tuberosity footprint, the deltoid over it. So this is the corresponding MR area here. The coracoid process would be over here. So if you were going to check for subcoracoid impingement, you may slide it even further medial and proximal, catch that coracoid process over here, and have them internally and externally rotate their humerus, and you may see bunching up of the tendon or bursa underneath it to suggest subcoracoid impingement, especially if the coracoid process is sort of coming in this way toward the humerus. You flip 90 degrees, and here is the subscapularis tendon at the footprint coming together, the multiple tendons coming together. So this is in short axis. The supraspinatus, so now you're going to have them change their position. There are several positions that you can have the patient move their shoulder into, but if you keep them in neutral position, a lot of the tendon will be obscured by the acromion. And so what you want to do is you want to have them do either a modified Crass maneuver, where they're going to bring their arm behind their back, sort of in a cross-arm type crossbar appearance, or you can have them do their hand in their back pocket. So you say, take your hand with your palm down towards your bottom and put it in your back pocket, and that will bring your supraspinatus out. And so this is the long axis of the supraspinatus. You can see it coming down towards the footprint. This is probably more the posterior supraspinatus, not really the anterior leading edge, but here you see the tendon right here, normal appearance coming over towards the footprint. And you notice that there is this hypoechoic region right at the footprint here. And you often see this, and this may be tear and this may be anisotropy. So you want to then come over and try to sit right on top of that footprint and rock the transducer and see if that fills in. And this is the same tendon as you come over the footprint, you can see that fills in. So this is anisotropy here. There is no real tear there. You can see the muscle coming in here. So the muscle comes in and forms this little triangular shaped structure right at the junction here. And so this is the muscle coming over, and then the tendon here coming out. The humeral head right here, this echogenic structure right here, this hyperechoic line, is going to be the subchondral bone plate, and then the cartilage sitting on top here. The deltoid on top of here, and if we go further over, you'll start to see the acromion. When you turn 90 degrees, this is going to be in short axis, and this is the sagittal view on the MR here, and so you can see the normal appearance of this tendon, normal thickness, there's no gap, there's no uncovering of the cartilage, and if you look right on top in between the deltoid and the supraspinatus, this would be where the subacromial subdeltoid bursa would be if it fills up with fluid, and so, or synovitis. In this case, there's no bursitis, it's collapsed on itself with this little echogenic line right here. Then you ask them put their hand on their opposite shoulder or Pledge of Allegiance type position. You come towards the back, angle slightly up, and in long axis you're seeing the infraspinatus tendon here, right at the footprint. You see the overlying deltoid subcutaneous tissues, the humerus here at the footprint, and we start sliding medially, and you're coming across. This is a different patient from an arthrogram, but as you're sliding across, sort of the more getting towards the mid-substance, and if you really keep coming back, you're going to get into the proximal part right near the joint, and so you can actually see here's the glenoid right here, the posterior labrum right here, the humeral head, a little bit of cartilage, and you can start to see the muscle coming into play in here. So this is the muscle sort of back here, again sort of at that junction of tendon, this dark or hypo-intense area, and then the muscle around it. And then you want to look at their muscles. So this is a sagittal turned on its side just to show you where the probe would be, but you come over to the scapula and you slide down here, and you're going to see this almost upside down W appearance. This is the infraspinatus tendon here, the hyperechoic region, and the muscle all the way around it. And so you want to then follow that out laterally toward the footprint. So this is us following the tendon out towards the footprint here, and you're coming out here. And again, in short axis, you see the infraspinatus and the humeral head right there. Moving on to the knee, so again, there are some structures you ideally want to see, and then you can tailor it depending on where they're having pain or if it's a full or a limited study. So some structures you may see the quadriceps tendon, the suprapatellar bursa, which is the joint, the patellar tendon, the MCL. You may see the peripheral third of the bodies of the menisci. Potentially you can see the peripheral third of the posterior horn if you come behind. Neurovascular bundle, look for Baker's cysts. You can see the fibular collateral ligament, or LCL, biceps femoris, the popliteus, Hoffa's fat pad, the prefemoral fat pad, the suprapatellar fat pad. As I mentioned, the neurovascular bundle. You can follow the common peroneal nerve all the way around the fibular tunnel and fibular neck into the leg. The tibial nerve, the medial hamstrings, and pes, answer, and bursa. You can sometimes look down at the trochlear cartilage in the IT band. Typically, the areas that we're going to be limited in terms of visualization are going to be things in the intercondylar notch or cartilage within the tibiofemoral compartments. So this is looking towards the anterior structures first, probably best suited to do a full knee ultrasound going anterior, medial, lateral, and posterior, and just covering your checklist. So this is the corresponding MRI. You see the hypo-intense quadriceps tendon coming down toward the patella, and then the patellar tendon coming down to the tibial tubercle, Hoffa's fat pad or the infrapatellar fat pad here, trochlear cartilage, patellar cartilage, and you can see the joint fluid coming up underneath the patella and into the suprapatellar bursa, the quadriceps or suprapatellar fat pad here, the prefemoral fat pad here. The corresponding ultrasound showing in long axis the quadriceps right here, overlying subcutaneous adipose tissue, the prefemoral fat pad right here with the femur down here, suprapatellar bursa, and the quadriceps or suprapatellar fat pad here. As we slide further down, here's the patella, and you see the patellar tendon coming down with that normal fibular pattern toward the tibial tubercle with Hoffa's fat pad deep to it, subcutaneous tissues on top. Coming medially here, you see the superficial MCL coming down here, this hypo-intense line with the body of the medial meniscus here, and you can sometimes see the actual vasculature coming into the peripheral red zone here, and that's usually represented by a line coming in from a non-articular side of the red zone of the meniscus. And here you have the femur and the tibia, and you can see the medial meniscus here, this peripheral third. This should be hyperechoic when there's not anisotropy. The MCL we are having a little bit of a difficult time seeing here, but it would be coming down over here. I changed the orientation a little bit, and you can better see the MCL. In this case, it's a little bit hypoechoic, but it comes down. So if you rock your transducer and kind of move things around, you may see the MCL coming down, especially when it's not injured. On the lateral side, so this is starting from the beginning here. So this is the femur here, the tibia down here, and this is the iliotibial band coming down to Gerdy's tubercle, and that's this right here. And then as we scoot further back, so I just blew up these images as we're coming from anterior to posterior, and on the next slide even further posterior. And you see the little notch where the popliteus tendon is going to be coming in. And in this case, you start to see it coming in, but it's actually attaching here. So it's looping around the popliteal hiatus to insert on the femur here. And this is the popliteus tendon in long axis. Seeing a little bit of that peripheral third of the lateral meniscus there as well. Coming further back now, and you're getting a good view of the lateral meniscus right here. You're seeing a little bit of that popliteus tendon here. We've already passed its attachments, and now we're seeing it making that curve. And then as you come further back, you see the biceps femoris. So here's the muscle of the biceps femoris and the tendon coming down towards the fibula. And you can see it here on the MRI, the muscle here, the tendon. You can rotate it and try to see its attachment at the fibula. I didn't show it in this case, but you can follow it all the way down to the fibula. And then you can turn and come a little bit more oblique and anterior and follow the fibular collateral ligament or LCL back up to the femur as well. You may decide to look at the common peroneal nerve at this point as well, or you can follow it from the posterior side at the sciatic bifurcation. So this is the posterior side, and again, usually just to look for the neurovascular bundle and maybe for a Baker's cyst. So I'm showing you the traffic light orientation of the tibial nerve, and then your tibial or sciatic, depending on where you are, and then the artery and vein. And so here you see the normal cross-section appearance of the tibial or sciatic nerve with these hypoechoic fascicles surrounded by echogenic connective tissue, and the vein and artery right next to it. So it sort of looks like a little traffic light. If you look further down, depending on the depth that you set, you may see the back of the femoral condyle. So here you see the femoral condyle and some overlying cartilage or joint fluid sometimes back there. The Baker's cyst, I have a whole presentation on how to look at a Baker's cyst with ultrasound, but this is the typical appearance of the Baker's cyst with the snow-capped peak turned on its side. This is the medial gastrocnemius and semimembranosus here with the Baker's cyst coming out. Remember that on both ultrasound and MRI, you need to make sure that it comes out between those two tendons, and even if it looks like a Baker's cyst, if it's not coming from there, you don't want to mistake it for a Baker's cyst when it's truly a sarcoma or something like that. So if you want to take a look at how to diagnose a Baker's cyst with ultrasound, check out my video on Baker's cyst imaging protocols on my channel. It's a quick tutorial on how to do it. So now I'm going to get into the part where I'm going to talk about some of these common MSK ultrasound guided procedures, and I'm going to pause just to at least give a second if you want to pause your screen to look at some of the evidence that I presented, but I'm not going to go into a deep discussion on the evidence because that's really outside of the scope of this. So the first thing that you may encounter on a question on an exam or in real life would be if you see this calcific density near the rotator cuff or bursa, it's going to show up as this hyperechoic material in the same area, and this is the calcific tendinitis, hydroxyapatite deposition disease, and you can lavage these with ultrasound. So you take your needle, you bring it right into the calcification, and you lavage it out. So there are many ways to do procedures. I'm just listing one way to do it, but again, you can, however you feel comfortable doing it, by all means, that is what will work for you, and there's plenty of discussion about this in the literature as well to review, but you want to perform this procedure, so-called barbotage, in the resorptive phase when the calcifications are more fluffy. It's typically more acute and easier to break up. Anesthetize the skin using the ultrasound with a spinal needle or even a shorter needle if you can reach it. Get into the center of the calcification, and then you're going to pulsate syringes, whether you use one or if you use the sort of multi-syringe technique, that's up to you, but you want to pulsate that calcification with a mixture of lidocaine, sterile saline, and periodically aspirate to bring that calcification out of the injured tissue and into your syringe, exchange it out for a new one, just keep repeating that so you can clear as much as you can. And then importantly, you want to put local anesthetic and a corticosteroid into the bursa because the particulate nature of the calcifications can potentially irritate the bursa and cause worsening pain. So a lot of people advocate for doing this as a way to control pain after the procedure. There are risks associated with this in any procedure at all. And here's a quick couple liner about a couple of papers describing efficacy of this procedure. I'm going to stop for a second and let you pause here if you want to take a look at this, and again, there will be a list of citations at the end. Okay, moving on. Biceps tenosynovitis. So it's rare to have it in isolation. It often accompanies labral pathology, but if you have biceps-related pain, tendinosis, tenosynovitis, especially over the bicipital groove, one possible procedure that can be performed is a biceps sheath injection. You want to bring your needle in and put it in, not through the tendon, but maybe right into the edge of the sheath, somewhere around the tendon, and inject, and you'll put your medication around the biceps tendon. This does communicate with the joint, so you will get some of this material diffusing into the joint and working there as well. You can, anywhere you see fluid is a good target, so even if you come distal like we did in this case, you can see the needle coming in, and where distal there was fluid, I didn't show the tendon here, but we came right to the side here and injected until we saw it filling up around the tendon. Any of that will work. Here is a post-injection further down in this case, and you can see the tendon with the fluid around it, and you can see these little echogenic reflectors in here, and this is sometimes you'll see the corticosteroids showing up as these little echogenic flecks inside of the fluid you're injecting. So the procedure, one way to do it under ultrasound, typically in the lateral approach, like I said, go into the lateral aspect of the sheath, don't inject the tendon, do a small test injection just to see it filling up around the tendon, and then inject the rest of your medication, the corticosteroid and local anesthetic. There are risks associated with such a procedure, and this does include infection and rupture of the tendon, especially with repeated injections or if you accidentally inject into the tendon itself. And here's a couple liner about some studies that talked about the efficacy. Okay, moving to the next one. Paralabral cyst aspiration. So this is in the shoulder. We see the glenoid right here. We see the humeral head right here, the posterior labrum here, the joint this way, and you can see this anechoic structure coming near the posterior labrum here. So this is a paralabral cyst, a sentinel cyst indicative of a tear of the labrum. And in this case, the patient was symptomatic from it. It was impinging on one of the nerves, and so the request was to drain this cyst. Now, this is potentially not going to cure the situation because you still have the labral tear and you still have potential for a one-way valve allowing fluid to accumulate in this, but can provide potential relief at least temporarily, and in some cases it may be longer lasting. So this is before, during, and after when we've decompressed the cyst here. So the procedure method, clean and anesthetize the skin, go with ultrasound guidance using typically a spinal needle, and get inside of that cyst. If it's really thick, viscous material, you may have to lavage it a little bit just to break up some of that material. A lot of the time the ganglion cyst will be like honey, and so if you use some sterile saline, you can sort of lavage and dilute some of that material so you can aspirate it. And some people will advocate for carefully under ultrasound guidance fenestrating such cysts, poking holes through the walls to try to avoid the ability of it to reaccumulate fluid, and potentially to cause a little bit of a bleeding response so that in theory the cyst walls may scar together. And then you may inject the remnant with some steroids. There are risks associated with it, and here is just a couple of lines about some of the studies describing the efficacy of this procedure. The next one is going to be injection into tendon sheaths for extensor tenosynovitis, in this case Dequeravain's tenosynovitis. We're looking at compartment 1 here, the abductor pollicis longus and the extensor pollicis brevis tendons. And so you may have a patient who has pain consistent with Dequeravain's or other types of extensor tendon tenosynovitis or tendinopathy. And so you bring your needle in and you carefully pull it into the tendon sheath. This will be backed up slightly because we're showing it that it's too close to the tendon, but you pull it back right into the periphery of it and inject into the tendon sheath just like we did with the biceps tendon. So again, anesthetize the skin after cleaning it, use a sterile probe cover like we would with all of our procedures, and in this case we're going to use a small hypodermic needle advanced in this case to the first extensor compartment and inject a small amount of local anesthetic and steroids. Risks associated with the procedure, and in particular with the first extensor compartment, you may be near the superficial branch of the radial nerve, so you want to be careful not to hit that. And then here's a couple of lines about the efficacy of these injections. The next one would be ganglion cyst aspirations in the wrist. In this case, this is a radial volar ganglion cyst. You can see it going down toward the joint here. There's no flow inside of it, but there is flow right here, and this is the radial artery next to it. And so some of these volar radial ones may be located near the radial artery, so you got to be really careful not to poke the artery while you're doing any procedures for this. So what would be done? You would again anesthetize the skin, clean it up, sterile probe cover, etc., and then using ultrasound guidance, use a small needle and go into the cyst and try to aspirate it. If it's very thick, you may have to lavage, and then if you want to fenestrate it, you can fenestrate it, but you got to be really careful that you're not going to damage the artery next to it. That's probably one of the biggest risks in doing that, so be very careful when these are near the radial artery. Risks associated with the procedure, and then some of the efficacy behind such a procedure. Keep in mind, just like with the paralabral cyst, if this is coming from a defect in the joint capsules or ligaments, this may reaccumulate and may not be curative. So that's why some people advocate for fenestration and then wrapping it to hope that the walls will scar together. Greater trochanteric bursitis, you may see peritrochanteric edema or frank fluid on MRI in this region near the posterior facet of the greater trochanter. This is all included in that greater trochanteric pain syndrome, which may be related to tendinopathy, tearing of these gluteal tendons, or bursitis, with ultrasound coming towards that posterior facet and injecting into the bursa. So again, sterile technique, use typically a spinal needle. You're going to go into the trochanteric bursa and inject a combination of local anesthetic and steroids. The risks associated with this procedure, which include eventual injury to the tendons or rupture, and then some of the data behind the efficacy of these injections. Parameniscal cyst. So this is a case of a parameniscal cyst of the knee, usually in the setting of a horizontal cleavage tear of the meniscus, and you can see this multiloculated cyst coming out of the meniscus here, the needle coming right into the cyst, and just like other cysts, aspirating, lavage if necessary, and fenestrating. This one, not as close to any major structure, so less risk than the ones near the radial artery. The procedure, sterile technique, ultrasound guidance, go into the cyst. You may not need to use a 3.5 inch, it depends on how much tissue is overlying this area, and then inject the remnant with steroids and local anesthetic. The risks associated with this, and keep in mind, just like the other cases, if this is due to a meniscal tear, it's not going to fix the meniscal tear, so this potentially can reaccumulate. And here's just a little bit on some of the papers talking about the efficacy of this procedure. Baker's cyst, the same thing. So you can always come into it and aspirate and fenestrate, put steroids in. This may reaccumulate, but for symptomatic patients, this is a potential option that's non-surgical. Sterile technique, anesthetize the skin, aspirate, lavage if necessary, and fenestrate carefully the walls, the risks associated with it, and then efficacy of this procedure. I'm just going to touch briefly on some of the commonly injected joints. I can do an entire talk just on ultrasound guided and fluoroscopic guided injections of joints, but I'm just going to touch on a couple of them. This is for a ultrasound guided hip injection. You're coming from anterior, and you're aiming sort of for the head-neck junction where you have more space underneath the capsule here, so the iliofemoral ligament slash anterior capsule for the hip here. This would be where your needle's coming through. This is another view. And so I didn't adjust for depth in this case, but you can still see what's going on. The patient actually has an effusion, so the capsule's lifted up. The head of the femur is here, coming towards the neck right here, the head-neck junction right here. You can actually see some synovitis, the acetabulum here. We're using a curved probe, which we often use for hip injections, especially if there's a lot of adipose tissue. And so you're going to see in this case the needle coming in, and there's the needle, and then I'm going to inject the steroids, and you see that particulate matter floating around inside of that joint. So just to show it again, coming through, and here's the needle right into this region. You don't necessarily have to hit the head-neck junction if you've got fluid to target, but if I didn't, typically I would come right around here, and the reason being because you have this dip in the bone here, and you have this relative increased space between the bone and the capsule. And then, like I said, when you inject steroids into fluid, sometimes you'll see the echogenic steroids sort of floating around inside of the joint there. So this is a ultrasound-guided hip injection. What about the ankle? Well, you can do it from a number of approaches. This is the anterior approach. This is for an arthrogram. And so you have the tibia over here, the talus down here. You can sometimes have them plantar flex their foot to try to open that space up a little bit. And there's a space down in between the bones here, and so you want to try to avoid the tendons if possible, and so sometimes it's a little challenging and you have to oblique your course. So I'm showing you the tip down here because I had to oblique it to not go through the tendon here. So the needle coming down into here, and you can see the tip of the needle down here. So if I had come straight through here, I would have had to go through this tendon here. But this is the tip of the needle down in the joint, the fat overlying it here, and you can see before the injection the fat and the joint synovial tissue right on top of the cartilage of the talar dome here, and after I inject you see that the capsule is lifted up here. So this is the fluid I've injected into the joint coming all the way around here, and that this is this fluid we just injected. Shoulder injection, there are many ways to do it. This is a medial to lateral posterior approach, and so you're seeing the back of the joint here. This is the glenoid side with the labrum over here, the humeral head right here. You're seeing the infraspinatus and the needle coming through here, and you're coming lateral to the labrum to make sure that you don't hit it. You have a firm endpoint, just like you do in fluoro. You're going to hit bone, and this would be the trajectory here. You come in here, aim the opening of the needle down towards the joint, and you try to inject it. If you're having resistance, you just slightly pull back until you see the feel the resistance drop or see the capsule start distending. And typically, because you are injecting into the joint, for, in this case, an arthrogram, if you inject high volume, you can actually see distension of the biceps tendon sheath at the end of the procedure just to confirm that you've gotten all your fluid inside of the joint. So if you inject 8 to 10 cc's, 12 cc's, 14 cc's, take a look at the biceps sheath pre and post, and you'll see the difference. So finally, I'm just going to finish with some cases here. This was a case of a sporting accident, and we're looking on the medial side of the elbow, and you can see the common flexor tendon has avulsed off of the epicondyle here, and the ulnar collateral ligament here, which is thickened, but avulsed off over here too. And so you can look on the corresponding ultrasound, you see this fluid gap here, the flexor pronator origin not reaching down to bone. And then I didn't show on this image, but when you obliqued it and looked down, you would see at the sublime tubercle the anterior bundle of the UCL, and then it came back and stopped abruptly. So there's nothing attaching here. So this is a medial sided tendon and ligament injury on ultrasound and MRI. In this case here, we're seeing the back of the shoulder. This is a dynamic ultrasound, and we're seeing the humeral head right here, the glenoid with the posterior labrum, and this is a torn infraspinatus tendon. The tendon stump is right here, deltoid here, subcutaneous tissues, and if we have this patient internally and externally rotate their humerus, you notice that the tendon stump right here does not come all the way out to the footprint and attach, and it's not moving at all as this patient is internally and externally rotating. So this is a dynamic ultrasound confirming complete discontinuity and retraction of this infraspinatus tendon. We compare that to this intact infraspinatus, and we see with internal and external rotation, the intact infraspinatus tendon going all the way to the footprint, and as this humerus is internally and externally rotating, it remains intact and moves with the humerus. The overlying deltoid right here and the subcutaneous tissues on top. So this is an intact and normal appearing infraspinatus tendon with the joint further back this way. This next case here, we're looking at the front of the shoulder. Here is the humerus with the attachment of the pec tendon here, and you're starting to see the biceps tendon coming out with the fluid in the sheath. And as we come from distal toward proximal, you'll notice in short axis this long head of the biceps tendon is medialized from the bicipital groove, the greater tuberosity here, the lesser tuberosity here. There is no subscapularis tendon here, and as we come cranially, you're seeing the conjoined tendon heading up towards the coracoid process. And as we continue our journey cranially here, you now see the echogenic cortex of the coracoid process with posterior shadowing and the biceps tendon dislocated medially and centrally into the joint. So the bicipital groove here, the lesser tuberosity, no subscapularis, and a dislocated biceps tendon. So this is a full thickness subscapularis tendon tear, a biceps pulley rupture with a dislocation, an intra-articular dislocation of the biceps tendon. We compare this now to an intact subscapularis tendon here, the lesser tuberosity. Over this way, the biceps tendon will be coming into view. The conjoined tendon and coracoid process are actually at the level of the coracoid here. And as this patient is internally and externally rotating, you see the attached subscapularis moving back and forth, and the biceps tendon coming into view here within the bicipital groove. You notice that although the subscapularis tendon is coming towards the coracoid process here, we don't see bunching up of the tendon or the bursa underneath it. There's not narrowing of this interval here, so there is no subcoracoid impingement. We don't see a dislocated biceps tendon. It remains where it's supposed to be located. So this is the normal appearance of the subscapularis and biceps tendon on dynamic ultrasound. Over here we have a x-ray showing a mass on the medial side of the knee. The pes tendon's coming down this way. I'm going to try to avoid showing masses. I'm just going to show a couple just as an example, only because I have a series of ultrasound masses on the channel, a bunch of videos showing different cases. So if you're interested in seeing more on ultrasound appearances of masses, take a look at some of those videos on the channel. This one, a cystic looking structure, and I showed this just because this is a comparison to that parameniscal cyst we saw. This is a true mass occupying space. It's on top of the MCL. It's not communicating with the meniscus. There's no meniscal tear in this case. It looks cystic, but cysts in weird places need to be confirmed to truly be cysts before you just chalk them up to being a cyst. So we did an ultrasound, and you can see that there's some complexity to it. There does appear to be some posterior acoustic enhancement, but you can see here's the MCL right here, MCL coming over, the medial meniscus down here. There's no continuity between them, and then we put color Doppler, and you see a lot of flow inside of this mass, low resistance arterial waveforms. This was a myxoid liposarcoma with no fat seen on MRI. In this case, we see a high-riding humeral head. We see some calcification where the rotator cuff should be, and it's not super easy to see, but if you look carefully at the soft tissues, there's fullness right here, and the patient actually presented with a soft tissue mass. And so I windowed this a little bit, and you can see the soft tissue sort of nodule up here. And so here is the rotator cuff. Here's the humeral head here, the deltoid sinking down and almost coming down with the bursa to the humerus here. There's no tendon like we saw before. So this is a full thickness rotator cuff tear. You can see a little bit of that tendon and maybe some of the calcification there, and again the sagging deltoid, which is a sign of a cuff tear, and then just complete discontinuity here. So here's your calcification over here. And then when we went up, you saw this rounded anechoic structure, and when you scrolled through on the cine, you saw a little tail coming down to the AC joint. So this is a cystic structure that communicates with the AC joint, typical location, no internal flow, and here's the corresponding MRI showing this cystic looking structure, which the PD signal is similar to that of what we saw with the myxoid liposarcoma, and so it was good to check it out with ultrasound, make sure there was nothing inside of it that was vascular or solid. And you can see here coming right down to the AC joint, the humeral head high riding. There's actually remodeling or acetabularization of the acromion. The AC joint is injured, and so this is a full thickness rotator cuff tear, destabilized AC joint with fluid extending through the AC joint and causing a cyst here. This is the so-called geyser phenomenon, where you would historically inject into the joint and see like a geyser, the contrast material going to the AC joint. The cyst is not necessarily the geyser phenomenon. The geyser phenomenon was that arthrographic description of seeing it shooting up into the AC joint when you injected the glenohumeral joint, but they can often form these cysts, and so you can aspirate these and fenestrate and things of that nature, but again, this is a joint fluid migration from the injured rotator cuff and AC joint into the soft tissues. So without fixing the anatomic defect, you're going to potentially have more and more joint fluid reaccumulating in these things. So this is a geyser cyst. Here we have another great example of a full thickness cuff tear. You can see the humeral head right here with the cartilage and the uncovered cartilage here, the uncovered cartilage sign. And the ultrasound showing here the acromion, the supraspinatus, and there's a big gap right here with the cartilage uncovered and a gap with the deltoid sitting on top here. And again, here's another example. In the same case, you come further out towards the footprint, you can see a little bit of remnant tissue, but there's no tendon right here. So this is a full thickness rotator cuff tear on ultrasound with corresponding MRI. This was an example of another way to do one of those posterior injections. This was an arthrogram. You have to be really careful when you do this approach that you don't shear cartilage and that you don't stick the needle tip into the labrum. So the labrum ending right here. If you can't see your needle tip, do not use this approach, because if you stick your needle into the labrum and do your arthrogram that way, or your injection, you're going to injure the labrum. But in this case, you can see the needle tip sitting right here in front of the labrum, and we injected for the arthrogram. But interestingly enough, when we did the diagnostic portion, rotated and looked at the short axis of the posterior muscle, so you see the infraspinatus here, and then you see this hyperechoic muscle right here where the teres minor should be, and this is the corresponding MRI showing the fatty atrophy of the teres minor muscle right here. So here's the teres minor, the infraspinatus, infraspinatus and teres minor. This was a patient with lateral ankle pain. You can see the peroneus longus tendon here, the brevis here with the split right here at the retromalleolar groove. I blew this up here and reversed it so you can actually see the orientation over here. So you're looking down, and here is the peroneus longus tendon, the peroneus brevis muscle, and here's the tendon up against the back of the fibula in the retromalleolar groove with this vertical tear splitting the peroneus brevis tendon into medial and lateral bundles. The ultrasound showing the same thing. Here is the peroneus longus, the brevis muscle right here, and the split brevis here up against the back of the fibula. And when we had the patient move their foot around, we could dynamically see this snapping tendon, because they presented with a snapping tendon that was torn. And so if you watch, here is the peroneus brevis, here's the longus, and when they move their foot around, you see it snapping past and then splitting apart that tear there. So I'm going to play this again, and you see it snapping past the tendon with this split becoming readily apparent. This is a case of a patient who presented with groin pain after a sporting injury. We're looking in the right adductor longus region here, and you can see this hematoma with this fluid gap here and injured tendon right here. The corresponding MRI showing the hematoma and the torn ends of the tendon here. So this is the same view here. You see the torn adductor longus tendon right there, and then the retracted and injured myotendinous junction back here. So this is an adductor injury on ultrasound with MRI correlation. This was a 23-year-old with medial-sided pain. You notice right away that there's a dysmorphic appearance of both knees here. And again, I'm going to try to avoid going too much into masses here, but this was a very interesting ultrasound case that I did not include on the channel for the other ultrasound masses, so I figured I would include this one. These are multiple osteochondroma, so this is multiple hereditary exostosis syndrome, and you can see them all over, sessile and pedunculated, and just all kinds of exostoses. And on the MRI, you see this exostosis coming off the fibula here with this thickened PDFS hyperintense tissue right here. So this is pretty thick. And the question was this cartilage or fluid? And this is probably going to be cartilage. And you see all these other ones without really thick caps. There's a tiny cap on this one here. We did an ultrasound. You can see the cap here. This is pretty thick cap, solid. There are these areas of anechoic regions within the cap, but most of this is hyperechoic with sort of a grainy appearance to it. Now this is compared to where the patient was actually experiencing symptoms. They had this other exostosis on the other side, and this, again, PDFS hyperintense material around here, not really with a convex margin. It sort of has this angular appearance, like it's not really space occupying. But without contrast, it's kind of hard to tell what we're looking at here. And so here's the corresponding ultrasound, and you can see that there were areas, this is with the color, so there was no flow but it made it look a little bit noisier, but most of it looked like this anechoic material here, and surgically, when they went in to take that exostosis down, they found an adventitial bursa. So these patients may get adventitial bursitis that can cause pain as well, and can impinge on tendons and nerves and things like that. And so the ultrasound can be helpful to tell these cartilage caps from adventitial bursa. This is a ganglion cyst. You can see the tail going down towards the wrist, and in this case on the radial side with the artery over here. And so just confirming the ganglion nature with the tail going down the joint. I'm going to play this cine clip, and you can see the tail coming up and this multilobulated cystic structure with the tail coming right out of the wrist here. And you'll notice that the artery comes right by it here, arteries and veins. And so you have to be really careful when you do this procedure that you don't hit any of these vessels wrapping around it here. And so on the MRI, just showing the same thing here. And if you notice, there's a lot of posterior acoustic enhancement, and it's not totally anechoic. There's echogenic foci within it, and some less echogenic but still not anechoic material. And so this is probably going to be one of those honey-like cysts where you may have a difficult time aspirating without lavaging. This is a patient with rheumatoid arthritis, and you can see that the knee is just filled up with this synovial proliferation. We've got an erosion here in the femur here, and erosions of the tibia here. You can see more of this synovitis here, and so here's the corresponding ultrasound, suprapatellar bursa here. You see this frond-like material within the bursa, thickening of the wall, and marked hyperemia here. And then you come to the side here, and you can actually see these erosions in the bone with this synovial proliferation here. So this is the popliteus tendon here on the lateral side. So this is a good case of rheumatoid arthritis of the knee. And then just showing you the cine here as we're coming through, you see the synovial tissue, ligament on the top. This is the MCL being buckled out by this synovial proliferation. And when you look at the bone, you can see these erosions in the bone, these marginal erosions due to the synovitis. And as you come around, you see that it's actually on both sides. I didn't scroll all the way through, but you can sort of see that there's erosions on both sides here. So nice case of active synovitis with bone destruction occurring in this patient with rheumatoid arthritis. In this case, a patient with a snapping ulnar nerve and ulnar neuritis. When you come over here and you look at the ulnar nerve, it doesn't really look that impressive, and you play. And so here is proximal to the cubital tunnel, and you see the normal fascicular architecture of the nerve. And as you start coming through, you're going to see as it gets to the tunnel here, you're going to lose that fascicular architecture, and it just becomes this glob right here. Here's the medial epicondyle. Osborne's fascia would be over here. And so then as you pass the tunnel, you start to see it beginning to normalize again. So normal and abnormal appearance of the ulnar nerve. In this case here, a patient who had a chronic ATFL injury. You can see an ossicle where it had avulsed off, the ossicle on MR here. And then this patient, again, showing the ossicle down here and either remnant of the ATFL or capsule. And they had laxity on exam, so we did a dynamic exam, and you can see the space really widening when we manipulated the ankle and foot here. So you can see the stretching here with that little ossicle in there. This was an interesting case. This patient was a paraplegic who did not have any open wounds at the time, but had this MRI. There was swelling, there was concern for infection. Post-contrast T1 showing this large area of non-enhancement around the pelvis with rim enhancement here. And the corresponding fluid-sensitive pulse sequence in these areas, not really showing simple fluid anywhere. But nevertheless, this was interpreted as infection, can't exclude osteomyelitis and septic arthritis, and so an aspiration was requested. So when we came to the ultrasound, we saw all this echogenic material all around the pelvis here with hyperemia, and so we didn't see any fluid to aspirate. So we asked for an x-ray, and sure enough, there was ossification developing. So this is a patient with heterotopic ossification that's early and immature and looks very ominous on MRI, but in this case was not a fluid collection that could be aspirated. This case here, a patient who had an injury during a tennis match with feeling a pop and then swelling in the medial side of their calf, and you can see this now almost chronic appearing or subacute to chronic appearing hematoma, just because you've got some dark signal intermixed there. There is some intrinsic high T1, but this is an evolving hematoma, and you flipped over here, and so you see the skin here, the overlying medial gastroc here, and then this hematoma in between the gastroc and soleus. So this is a tennis leg type injury. This is a patient who presented with history of psoriasis and sausage digit on exam per the rheumatologist, and the third and second digits were swollen, and you can see the normal fourth digit here. And if you look carefully at the second and the third digits, you see that there's increased soft tissue on the volar side, and in the same area on ultrasound you see this synovial proliferation, this hypoechoic material with some fluid in it, and especially even more proximally we saw a lot of fluid, a lot of hyperemia. So in this case the sausage digits were at least in part due to severe flexor tenosynovitis, which may be seen in psoriasis. So in summary, MSK ultrasound is a powerful tool. It's cheap compared to MRI, but it's operator dependent. So you need to have a very good understanding of the anatomy and the pathology that you see in the area you're imaging. But you can use it, unlike MRI and CT, to assess for dynamic changes with respect to structures, which is important, especially for musculoskeletal injuries. A variety of ultrasound-guided procedures can be performed to help alleviate patient suffering, and it's important to look at the body of evidence for doing these procedures before you decide to do those in your practice, because it's a work in progress and is constantly evolving. So just make sure that you are staying up to date with the evidence for what you're doing. And that's what I said down here. And then these procedures, they're minimally invasive, relatively safe, and can be performed rapidly in an outpatient setting. Hopefully this talk will help prepare for the board exams for the radiologists and for other people out there who are not studying for boards, just to become more familiar with MSK ultrasound from a diagnostic and procedural perspective. Here are some of the sources that I have used in the past, and I would suggest taking a look at if you're interested in some of these procedures and for other information. The ESSR website is a great website just looking at anatomy and how to perform these exams from a diagnostic perspective, so I would definitely suggest taking a look at those. If you need to look at these, just go ahead and pause the video and get these links off of here. If you like this video, please make sure to put a like down below and comment in the comment section if you have anything you'd like me to cover on future videos. And as always, please share this video with your colleagues. I'm hoping to get more input as to things that would be helpful on the channel to my subscribers. So thank you very much for stopping by, and I'll see you next time.